On behalf of Pollen Healthcare, I warmly welcome you all to today's webinar. It is my pleasure to introduce our speaker, Dr. Partha Mukhopadhyay, MD DNB consultant clinical oncologist with over 30 years of experience in oncology. Studies currently associated with Ruby General Hospital. Today's session is on management of cancer cachexia through targeted nutritional therapy. Thank you, sir, for joining us. I hand over session to you.
Good evening, everyone. Uh, it has been a busy day today, and as we are drawing towards the end of the day, it gives me immense pleasure in presenting this short webinar to all of you, which is basically on the management of cancer cachexia through targeted nutritional therapy. Now, if you go into the deeper aspects of management of cancer cachexia, it may not be the right platform or the right forum to discuss the entirety of cancer cachexia, but what you should all understand is that there is a term called targeted nutritional therapy. Now, targeted therapy is the buzzword and immunotherapy is the buzzword in oncology practice nowadays. But have you ever heard of targeted nutritional therapy? This is the one where I'm going to present about the management of cancer cachexia through targeted nutritional therapy. Welcome to the session, and let's start straight away. By definition, cancer cachexia is not simply starvation, it is a complex metabolic syndrome driven by systemic inflammation. As we go on with the presentation, I will tell you about the systemic inflammation also. But you must all understand that there is a high prevalence of cancer cachexia in our patients, especially the Indian population that we deal with. It affects about 50 to 80% of patients with advanced cancer. And as the cancer cachexia progresses, there is a clinical decline. There is a progressive loss of muscle mass, and there is a functional decline in the activity of the patient also, with or without fat loss. It has, if it goes untreated, it has a severe mortality rate and contributes about 20 to 30% of all cancer-related deaths, and it also compromises on the treatment delivery and the treatment outcome also, increasing the hospitalizations during the course of the treatment. Let's move on to the next slide, please. Can I have the next one? Next slide, please.
Yes, sir. It's working on and it's visible. Is it visible to you, sir?
No, it's not visible to me, but I have a PowerPoint
Okay, sir.
presentation open.
Yeah.
So this is the third slide, I believe, the third slide, and this is the third slide, and it is dealing with the stages of cancer cachexia. Cancer cachexia, it progresses through three stages. One is pre-cachexia, or then comes the cachexia, and then there is refractory cachexia. Let's talk briefly about these three stages. Pre-cachexia is early metabolic changes. There is a reduced appetite, and there is less than or equal to 5% of weight loss in the patient. This is an early stage, and we see it in almost every patient. Every patient that they come to treatment with us, they complain of reduced appetite and loss of weight and all those things. So we must identify that this might be the case where the patient is entering into the pre-cachexic stage or the early stage of the cancer cachexia syndrome, the full-blown syndrome. Then comes the cachexia proper, where there is a progressive muscle loss with more than 5% of weight loss, reduced food intake, systemic inflammation, and declined physical activity. We all see these in our patients, and it's only that I'm classifying them into different categories here for your understanding. But the clinicians, we all see this pre-cachexia, cachexia, and then there is refractory cachexia when there is advanced treatment-related resistant disease, severe muscle wasting or sarcopenia, poor performance status and focus on symptom relief and quality of life. That's what we focus on. We say that this patient is beyond any kind of curative treatment now, and so we are focusing on improving the QAL and the symptom relief. So, but if we can identify the cachexia or the spectrum of the cachexia from pre-cachexia to cachexia before it progresses to refractory cachexia, maybe we will be doing justice to the patient. And not maybe, we will be doing justice to the patient. So, early identification and timely nutritional intervention are key to improving outcomes. And that's what I'll be going to speak to you about today. Next slide. Next slide talks about how this inflammatory cytokines, how they are released from the tumor and how they lead to the muscle breakdown and weight loss, and then there is functional decline and poor outcome of the treatment. So cancer cachexia is different from caloric deficient or starvation, which predominantly utilizes fat stores, and but tumor-induced inflammation actively categorize in cancer cachexia. Tumor-induced inflammation by different inflammatory outcomes, cytokines uh, like interleukins and all those things, they catabolize the skeletal muscle also, leading to sarcopenia. And this is where we target, or with the targeted nutritional therapy. That's what we call it, the targeted nutritional therapy, where it prevents muscle breakdown and weight loss and the functional decline and poor treatment outcomes. Next slide, please. So this is a cartoon where you can see how early targeted nutritional support can preserve the muscle mass, improve treatment tolerance, reduce complications, enhance recovery, and improve QAL. This slide actually is a ready reckoner of how targeted nutritional support can really alter the treatment outcome of the patient. It's sometimes we think, the clinicians, we think that why do we need to add targeted nutritional support to the patient? The patient is doing well otherwise, rather than if a little bit of weight loss and loss in appetite, he is fine. So, but that is, we must all remember, that is the early stages. This will progress during the course of treatment, and if we don't act early in such patients, we are going to compromise greatly on the treatment delivery and the outcome. So there is a paradigm shift now. Nutrition must be prescribed at diagnosis as a primary adjunctive therapy, not withheld until severe weight loss occurs. So this is the take-home message, that while we are starting on a radical treatment, maybe a radical chemoradiotherapy for a patient, the nutrition part of it, the nutrition part of the patient's treatment must be taken care of by giving that early adjunctive therapy. Next slide, please. I'll go on with the slide. This slide depicts about the pathophysiology of the cancer cachexia. Now there is a tumor, and the tumor releases inflammatory cytokines, as I was telling you earlier. This is IL-6, IL-1 beta, and TNF alpha. And these inflammatory cytokines, they cause systemic inflammation, and which causes hypermetabolism. Hypermetabolism is basically decreased in protein synthesis and increased in protein breakdown. And this is what a catabolism is basically, where there is increased protein breakdown but reduced protein synthesis. This leads to muscle wasting plus fat loss, as I had told you earlier also. And this muscle wasting and fat loss must be targeted by targeted nutritional therapy. And what does this targeted nutritional therapy? It comprises of high quality protein, essential amino acids like leucine, isoleucine, valine, and etc., omega-3 fatty acids, and vitamin D. So this will prevent the muscle wasting and fat loss, and this will thus prevent weight loss, reduce treatment tolerance, and poor clinical outcomes. So the positive effects are, it preserves muscle mass and strength, reduces inflammation, improves physical function, enhances treatment tolerance, improves quality of life, and leading to better clinical outcomes. So the key message is targeting the wasting process can break the cycle and improve outcomes. So this slide is very important, where we are showing by cartoon about the how we are targeting the the muscle wasting and fat loss. The next slide tells you in details about targeted nutrition. So what does this targeted nutrition actually is? What is this targeted nutrition or the targeted nutrients in cancer cachexia? This is very high quality protein. It helps in preserving the muscle mass. Then there is essential amino acids or branched chain amino acids like leucine, isoleucine, valine, etc. Stimulates protein synthesis. Then there is HMB, which reduce muscle breakdown. Then there is omega-3 fatty acids. Omega-3 fatty acids mainly of the animal origin, which supports inflammatory balance. L-glutamine supports gut integrity. Vitamin D supports muscle function. And zinc and selenium improve support and antioxidant defense. So these are the targeted nutrients which we want to target. It's a metabolic target actually. That there is no receptor or anti-receptor in this case. This is a metabolic targeting where we are targeting the nutrition aspect of the treatment by giving high protein, high quality protein, amino acids, HMB, omega-3 fatty acids, L-glutamine, vitamin, zinc, and selenium, which are important minerals. A combination of these targeted nutrients supports muscle preservation, immunity, and recovery of the patient. So this is a escalation ladder. We all know, we all deal with cancer pain, and there is a WHO ladder in case of cancer pain. Similarly, here in cancer nutrition or medical nutrition, there is an escalation ladder. The step one is always, the first line is oral nutrition and diet modification. If the patient is able to take orally, and then the first line of treatment is oral nutrition, where we are not feeding him with tube, we are not feeding him with IV solutions, but we are emphasizing on the oral intake. So what are the tools here? There is dietary counseling. Very few oncologists of us, they regularly send for an early dietitian consultation in case where we are treating cancer patients. We do send for dental evaluation. We do send for the audiometry tests, but we never send for a nutritional assessment at the beginning of the treatment. Make it a point to send patients of cancer, especially in the head and neck region or in the thoracic region, and to some extent in other regions also, but the head and neck region and the thoracic region, they are the ones who face the most of the difficulties, and you should always do a dietitian counseling or dietary counseling at the beginning of the treatment. Then there is food fortification. Then there is oral nutritional support, which we give to the patients with high protein and high caloric profiles. Indications: patients has functional GI tract and can safely swallow. The swallowing part of it is okay. So we can start as step one with oral nutrition and dietary modification, and high quality protein supplements are one of the major impact holders in this. The step two is enteral nutrition or EN, where we use it as a second line of treatment, and it is through nasogastric tube feeding or Riles tube feeding. The indications are inadequate oral intake despite ONS. Functional GI tract is there, head and neck or upper GI cancers preventing swallowing, like patients of oral cavity oropharyngeal cancers, patients of hypopharyngeal cancers, or patients of postcricoid upper esophageal cancers. Then, as a third line, the third line is parenteral nutrition. This should be reserved for patients who have a non-functioning GI tract with severe mucositis, bowel obstruction, or severe malabsorption. We can use it, or we should use it, only when enteral nutrition is contraindicated. So we see that the step by step oral nutrition with oral nutritional supplements, then enteral nutrition, and then parenteral nutrition. Managing cancer has always been a multidisciplinary approach. We do it on a regular basis, but we do it with the multidisciplinary management of cancer doesn't involve the dietary team or the dietitian team very often. We should, in the Indian scenario, we should always include a dietitian in the multidisciplinary clinical pathway for management of cancer, and especially in the management of cancer cachexia. So the team must consist of an oncologist. It can he or she can be a clinical oncologist, a radiation oncologist, a surgical or a medical oncologist. Must is a nurse. Must is a dietitian who will guide about the different aspects of feeding for the patient, including enteral and tube oral feeding. Then there is a nurse who takes special interest or counsels the patients about the day-to-day activities or the day-to-day feeding habits for the patient. Then there is pharmacist, and then palliative care. We have a feeling that palliative care is a care that we give to patients only when the patient is beyond cure. No, not always. Palliative care should be integrated into the spectrum of management of cancers right from the beginning. Palliation doesn't mean that we are palliating the cancer. We can palliate or uh, we can improve the cancer pain and all those things from the very beginning, which actually helps in the delivery of the treatment to its desired extent and improves the outcome of the treatment. So, if we uh, uh, move from screening, first we have to identify at-risk patients upon initial cancer diagnosis, as I told, head and neck cancers and thoracic cancers, including lung and esophagus. They are the ones which we should assess after screening. We should assess them to conduct comprehensive metabolic and nutritional profiling. It can be done to some extent in our busy schedule, but yes, we have to do an initial assessment. There are various tools available. I won't be going into those details in this presentation, but I will just mention them in my next slides or so. Then after assessment, we must diagnose the patient to be in pre-cachexic phase or cachexia or refractory cachexia. And after a correct clinical diagnosis, we must intervene in the fashion that will help the patient in doing in getting the treatment done without much problem. And it can be oral, enteral, or parenteral nutrition, but parenteral nutrition should be reserved for the last. And finally, we monitor the patient continuously, reassess metrics and the treatment tolerance. The next slide is a busy slide, but I must, if I tell you about this slide in simple ways, there is a high metabolic demand for the patient. The patient requires elevated energy and protein to combat the enhanced catabolism. As I was telling you earlier also, there is an enhanced catabolism in such patients. The anabolism part is less. The catabolism is more. And there is restricted oral capacity for the patient to take standard meals. So in this scenario, we must start with oral nutritional support or ONS. The clinical criteria in ONS is high. The product should be high in high quality protein with energy dense in low volumes, enriched with essential vitamins, minerals, and targeted nutrients. Targeted nutrients I have already told. It's easy to consume, digest, and tolerate. And as usual, we give small frequent feeds for this patient, and this management or the way the oral nutritional support and symptom management leads to it really bridges the gap, complementing, not replacing the balanced diet when oral intake is medically compromised. Next slide, please. So there is a global consensus, a unified guideline recommendations for the nutritional support. Assess early, routine screening for nutritional risk at cancer diagnosis and repeatedly during treatment. We must include it in our day-to-day review charts, especially for radiation oncology patients, the upper GI cancers or the lung cancers or the head and neck cancers. We must assess early, intervene immediately, do not wait for severe weight loss, initiate ONS early. Prioritize the gut. Enteral nutrition is vastly preferred over parenteral wherever the GI tract is functional. As I've been telling you throughout this presentation, that enteral nutrition is the one, or if the patient is not able to do a oral feeding, then tube feeding, but it should be enteral nutrition. Parenteral should be reserved for very, very refractory cases only. Measure muscle, not just weight. Utilize CT scans and functional assessment to track sarcopenia, as BMI alone masks muscle loss. Here, apart from CT scans, we must also understand that DEXA scans are also very important and in assessment of the sarcopenia and the muscle loss. And finally, team-based care. A team approach to the nutrition must be fully integrated into oncology care pathways, not treated as an afterthought. As I've been emphasizing throughout the talk, that the nutritional assessment has to be done early in the course of treatment, and appropriate intervention has to be done at the time that it demands. So, end-to-end clinical flow chart. If I summarize everything, first is identification, the cancer diagnosis. Then phase two is the strategy, comprehensive assessment, including the nutritional assessment. Phase three, high protein standard diet, and phase four optimization. So, how we do it, the clinical screening, there are several uh, preset guidelines for that, and some of these are PGSGA, MUST, and NRS 2002. Then there is, in comprehensive assessment, every patient of cancer must have an individual nutrition plan and diet counseling. Standard high protein diet, escalation to oral nutritional support, and escalation to enteral support if strictly required, and regular monitoring and reassessment. Every patient must have a monitoring dashboard where we track weight changes in percentage, dietary intake volume, muscle mass retention, PGSGA score shifts, and functional status and treatment tolerance. So there are four phases of the entire clinical flow chart, from cancer screening, cancer diagnosis, comprehensive assessment to individualized nutritional plan, and of course, adding high standard protein, ONS preferred over and enteral nutrition preferred over parenteral nutrition, and we should have a patient specific dashboard of the for the entire duration of treatment. So I'll just conclude my presentation today with two case studies. The first one, it was a nutritional recovery in acute lymphoblastic leukemia with neutropenic sepsis. The patient profile is a 64-year-old female diagnosed with B-cell acute lymphoblastic leukemia. There were post-chemotherapy complications in the form of neutropenic sepsis, liver toxicity, severe mucositis, hypoalbuminemia, and lung infection. That is, which is very common in when we are treating acute leukemias. The nutritional challenge was poor oral intake due to severe mucositis as a result of the chemotherapy, progressive weight loss, high protein and calorie requirement during chemotherapy. So what we did is that in this case, we started on Maxotin Onco from the third chemotherapy cycle, 2 scoops twice daily, continued until the 6th chemotherapy cycle, along with standard nutritional support. And what was the clinical outcome? The weight improved from 53 to 56.5 with a gain of 3.5 kilos. Albumin improved from 2.5 to 3.4 gram per deciliter, reduced severity of mucositis, improved nutritional intake, and better overall clinical recovery and quality of life. I must emphasize that this from third to sixth, third, fourth, fifth, and sixth. So over these 4 chemotherapy cycles, the gain in the total weight gain was about 3.5 kgs, which is very, very good in considering the type of highly toxic chemotherapy, that the induction chemotherapy that these patients receive. So the key takeaway is early nutritional intervention with Maxutin Onco supported weight recovery, improved nutritional status, and enhanced clinical outcomes during chemotherapy. The second case study is about a 43-year-old male with esophageal cancer with severe dysphagia and was severely underweight at the time of presentation. He was hypertensive but non-diabetic. Weight was 47.1 kilo. BMI was 15.7 kilo per meter square. So he was severely underweight, difficulty in swallowing, and assessment date was 19th April 2025. So the nutritional challenge was severely underweight, dysphagia leading to poor oral intake, risk of further weight loss and malnutrition because he was a patient of esophageal cancer, and need for high protein and easy to consume nutrition. We did intervene with Maxutin Onco. We started with 2 scoops twice daily in the first week of June 2025, continued with standard nutritional support with ongoing supplementation. The clinical outcome was there was a total weight gain of 3.9 kilos over 3 weeks. That's marvelous, actually. 3.9 kilo of weight gain in 3 weeks cannot be expected in a patient who is severely malnourished and severely underweight due to esophageal cancer. The weight improved from 47.1 kilo to 51 kilo. Improved nutritional intake and tolerance, positive trend towards recovery and better quality of life and clinical process. The actual oncological treatment, it continues side by side, but the nutritional aspect of the patient, the nutritional requirement of the patient should be diagnosed early, and intervention should be done early so that we give the patient a chance to complete the entire treatment, the planned treatment, without much problem. So the key takeaway is that Maxutin Onco supported effective weight gain and improved nutritional status in a patient of esophageal cancer with dysphagia who was severely underweight. So this brings to the end of today's presentation, and I'll be happy to open the forum, open it for discussion. If there is any question, there are any questions, I'll be happy to answer them.
So from the forum, if anyone has any query or questions, so please feel free to ask. Sir is here for next couple of minutes. Sir has taken time for us in his busy schedule.
I think there are
So
no questions. Presenting very good, actually. Everything is understood. Huh? So
absolutely, absolutely, sir. You have taken it so deeply and so nicely that everyone has gone through those case studies and the entire flow chart of nutrition in cancer cachexia patients. So, on behalf of Pollen Healthcare, I, Mohammed Parish, would like to say thank you so much for your time and putting the valuable insights on this webinar. So, thank you so much, sir.
I'm really honored to be a part of your uh, presentation team today, and let's hope that we meet more frequently from now on. And as far as my practice is concerned, I have now started to include the dietary part of it in every patient of head and neck cancer and upper GI cancers at least. And would
Definitely,
also
sir.
ask the participants to do the same also. Thank you.
Thank you so much, sir, and thank you all the participants for giving your valuable time. Thank you.
Thank you, sir. Thank you.